All right. Well, hello, everyone. Sorry about the little bit of technical difficulties there. As Jamie said, I'm Dr. Kelly Seeps. I'm the optometrist at Vance Thompson Vision in South Sioux City. And Dr. Tanner Ferguson is joining me today as well. He is one of our surgeons who splits time between South Sioux City and Sioux Falls. Today, we will be talking about supplemental skills. So main thing for this lecture will just be emphasizing the importance of obtaining good preoperative measurements. So when patients are coming in for a LASIK evaluation or a cataract evaluation or any sort of surgical evaluation, where we always obtain a series of tests that help guide our surgical decision making. This lecture will focus more specifically on cataract testing and intraocular lens measurements, so the lenses that we place in the eye at the time of surgery. We'll be talking about those measurements and what exactly is it measuring and how does it determine the lens that gets placed into the patient's eye. And then we'll also be talking about some other supplemental skills that some of you may have had to run in addition to regular cataract evaluation testing that can help us determine, is this a cataract that's really affecting the patient's vision? Is there something else going on here? Just additional tests to help us guide our surgical decision making. And just feel free to stop me at any time if you guys have any questions. Just a quick recap of the anatomy of the eye. So whenever we look at something, light is bouncing off of that and it travels into our eye. It first is going to hit our cornea. The cornea is the clear front window of the eye, and it contributes to almost 2/3 of the refractive power of the eye. Refracting meaning that all of the light comes into our eye, it gets bent and then focused into a focal point. And then it travels through our cornea, into our eye, through the pupil, which is the hole in the middle of the iris or the colored portion of the eye. Behind that is our crystalline lens. The lens is the structure in our eye that helps to focus the other 1/3 of the refractive power of our eye. The lens, when we're born, it's perfectly clear and very flexible. It's able to focus light if we're looking all the way out in the distance and then all the way up close to our face as well. That's a process called accommodation. Eventually, though, in everyone, if we live long enough, the lens becomes cloudy, and that is a cataract, and that's what makes it harder for patients to see. Eventually, the light makes it back to the retina. The retina is like the film of a camera, so it captures all of the light that comes into our eye. It processes the size and shape and color of whatever it is we're looking at, and then it sends that information through our optic nerve. Our optic nerve, I like to think of as the cord that plugs our phone in, right? If someone came and cut our phone charger, our phone wouldn't charge. Same thing in the eye. If there's any optic nerve damage, our optic nerve can't transmit that information. And so if there's optic nerve damage, that causes vision loss. So the optic nerve takes all of the information processed by our eye and our retina to our brain, where it's turned into what we perceive as sight. And so we will be mainly, like I said, focusing on the lens in cataract surgery, but we will come back to some of these other structures as well. Main thing is that all of these things have to function perfectly together in order to provide perfect vision. So we will move on. If there's any questions about that, let me know. So again, today we're going to be focusing mainly on cataract surgery. Cataract surgery, initially an incision is made into the cornea. There's 2 small incisions in the cornea. Instruments are put through those incisions, and they do what's called phacoemulsification, which is when ultrasound energy is used to break that lens up, the cloudy lens up, into multiple different pieces. Those pieces are liquefied and vacuumed out of the eye at the same time. Once the cloudy cataract is removed, there's an open capsule, which is where the intraocular lens is inserted. And as you can see in that last picture, that shows you what it looks like once that intraocular lens is inside of the eye. It's nice because it goes in the exact same place that our natural lens goes. So it's pretty convenient that it works that way. Next, we'll move into the actual measurements that are obtained at the time of a cataract evaluation to ensure good surgical outcomes. Dr. Ferguson, I don't know if you want to take over or if
Sure.
you want to keep going until you're
Yeah.
ready.
Can you guys hear me?
I can hear you. Yep.
Okay, perfect. So I'm Tanner Ferguson. As Kelly mentioned, I'm one of the surgeons and I work in both Sioux City and Sioux Falls offices. And so biometry is the phrase we use to describe obtaining the measurements or the key set of measurements for doing cataract surgery, and then calculating the power of the lens that we insert inside the eye to replace the cataract that we removed. So historically, they called this basically getting like A's and K's. That was the phrase people would use. And that refers to getting your axial length, which is how long your eye is from the cornea to the back posterior, kind of close to your optic nerve, posterior surface of the eye. And then K's would represent the curvature of your cornea. And there's usually like a K1 and K2. So the average power curvature is about 43. And so if your cornea was, at 90 degrees or vertically a 43, and then horizontally was a 42, your average corneal power would be 42.5. And that difference between the two, we call meridians, so vertically versus horizontally, is also what defines the astigmatism of your cornea. And these are the measure that goes into the calculation for A's and K's and then calculating the lens power. Now, over time, these, we call them formulas. The formulas are what we use, or we plug in these numbers. And most of these now are built into these biometers to calculate a power of lens. So like I said before, historically, we used A's and K's. Now we use a variety of things. We use anterior chamber depth. Some formulas use what's called the white to white measurement. There's just a number of different variables people use, and these are always changing. But modern day formulas are what we call fourth generation IOL formulas, and they're defined by an inclusion of your anterior chamber depth. The other thing I'll mention is that each lens has a specific A constant. And so you'll see these numbers on like an IOL box. It says like 119.1 or 118.7. or 119.7. And these are like a constant that are specific to each lens that goes into the calculation. And so sometimes companies will adjust their A constant after a lens is introduced to the market because they notice that people are ending, a certain divergence away from the target. For example, the light adjustable lens, which many of you are aware of, or all of you are aware of, was introduced in 2019. And then they noticed that people were ending up a little bit hyperopic or on the plus side versus the target. And so the company recommended a change in the A constant for their IOL to be used in formulas. The things that we don't need for calculating a power of a lens are like the corneal diameter, like how wide or how vertically long the cornea is, or your refraction. And the reason why a refraction is, it's definitely has importance in cataract surgery planning and can give you some clues on, maybe some additional tests to include or like how nearsighted or farsighted somebody is. But we don't need the refraction of a patient to calculate a new power of a lens. In fact, sometimes people will be sent in and they have, one diopter of astigmatism in their refraction. But if you think about your refraction as the refraction of the entire eye, which includes your cornea, your anterior lens, or your cornea, your lens, and then representing the whole optical system, sometimes that lens can also be influenced via astigmatism number. And that's why we look closely at the astigmatism value that we measure with the cornea versus what is currently in the patient's refraction. So, for example, somebody could have a half diopter, a 0.5 in their refraction, but on their corneal measurement, they have 1.5 diopters. And what that tells us is that the patient has some astigmatism in their lens called lenticular astigmatism that is compensating in the opposite direction of the cornea to contribute to them having only a half diopter in their refraction. What that also means is that when we do cataract surgery and we remove that lens that's contributing to the lenticular astigmatism, they're going to be, we know for sure they're going to be left with 1.5 diopters of corneal astigmatism. And so that's why sometimes we'll talk to a patient who may be seeing well without glasses before surgery because their lens is compensating for their corneal astigmatism, but we're going to unmask that at the time of surgery. And so that's why we'll talk to them about correcting their astigmatism at the time of cataract surgery with what's called an astigmatism correcting or toric lens. Where are we at? Okay, so axial length, as I mentioned. So the axial length is how long your eye is. The average length is about 23. That's like a normal average axial length of an eye, 23 millimeters or like 2.3 centimeters. And that kind of gives you an appreciation of how long your eyeball is. And the axial length technically is the distance from the front surface of the cornea to the back posterior surface of the eye. And so this is the measurement that's the most critical for getting an accurate IOL power calculation. Reason being is that the historical formula we used for cataract surgery, kind of like the first one, was called the SRKT formula. I don't really understand where those letters come from or what they mean, but that was the name of the first formula. And the SRKT formula was basically P, power equals A times a number minus the A constant, or excuse me, A constant minus this P or A number minus the Ks. And within that formula, the axial length is multiplied by 2.5. And so if you can imagine like an axial length of 21 being measured by 2.5, if you accidentally plugged in 27 instead of 21, if you take 6 times 2.5, which I think in my math is in my head is right, is 15, your lens power measurement would be off by 15 diopters. So there'd be a 15 diopter IOL calculation miss. And so if you think about that formula and you come back to it as, 2.5 times the axial length, that can help you appreciate why having a inaccurate axial length can throw off these numbers. It's also why, we look very closely when we're evaluating these calculations if the numbers are different between two eyes, because most humans are very symmetric, including their eyes. And so if the right eye is calling for a 21 diopter powered lens and the left eye is calling for a 17 diopter powered lens, if we're getting any flags that the measurements are inaccurate, we'll have a very low threshold to repeat those measurements because we don't want to miss inaccurate measurement of their axial length or inaccurate measurements in general. But if you did have like a 0.5 or a 1 millimeter difference between the two eyes, that is what can produce that level of difference between the two eyes. And as Kelly has included on these slides, precise measurements are needed to accurately calculate the power of the lens. And as you noted on here, about a 1 millimeter difference in axial length can lead to almost a 3 diopter difference in refractive error. You also can see here, looking at these numbers, so I said, an average axial length of about 23. Greater than that is people are usually myopic. They have a longer eye, or nearsighted, which means that without glasses or correction, they can see things up close. And when somebody has a longer eye, and that's what's contributing to their eye being nearsighted, that's called axial myopia, coming from axial length. Now, if they had a axial length of like 23, but they had, we kind of talked about these corneal measurements called Ks. If they had Ks that were higher than 43, so say like a 45 to 46, we would call that refractive myopia. And so that's where those two terms come in play. Now, if somebody has a another like clue you can get from axial length, this is like not always the case, but is a good rule or good like clue to follow. If somebody has had prior refractive surgery and you're trying to understand if they had a correction for myopia or hyperopia, you can look at the axial length as a clue. For example, most people who have an axial length of 27 are nearsighted. So you then know or have a clue in that most likely that patient had um, myopic refractive surgery. Or if a patient has an axial length of 21, meaning that they are farsighted or hyperopic, most likely they had a hyperopic LASIK treatment. And so those are just kind of things that you can look at with axial length that can kind of clue you in to give you more information about the patient. And there's different ways to measure axial length. Historically, we use something called applanation or immersion. These are what's called contact-based methods in which we have to actually touch the eye to obtain the axial length measurement. And then there's also something called coherence interferometry. Those are largely like the modern tools we use. So many of you are probably familiar with LensStar, Argos, or IOL Master. And those are the three most common instruments we use for biometry. I think most of our centers use a LensStar, but we also have an Argos at various centers, and they all use this called coherence interferometry, and they also kind of use what's called swept source OCT. And then intraoperatively, we also have something called intraoperative aberrometry, which is something we use at some sites that can also give you these similar measurements. So ultrasound for axial length. Sometimes we need to do this when somebody has a really dense cataract because the light that enters through the lens to obtain these measurements, we have to be able to get through that lens. Now, sometimes if the lens is too dense, like a super dense cataract, that light will travel. We're unable to get accurate measurements. And it's usually an issue with the axial length. And so we can use ultrasound, and ultrasound's super important. And there's two forms we kind of talked about before, applanation and immersion. And the advantage of immersion is that it gives you improved accuracy. It's less dependent on the operator. It's more consistent with the alignment. And then it gives you what's called a true axial length. Sorry, somebody's calling me just a second. And then applanation. So applanation, a little bit more user dependent. And if you compress on the cornea, that can falsify your axial length measurement. And as we mentioned before, having an error in the axial length can lead to errors in the IOL power calculation. And then B-scan. So B-scan is another tool we'll use in the setting of a dense cataract because, of course, before we do cataract surgery, we want to take a good look at the posterior segment representing the region behind the lens, including the retina, vitreous, and whatnot, optic nerve. And if the lens is so dense that we can't get a view, we want to make sure that there's no retina pathology that should suggest that cataract surgery is not a good idea or they need to go to retina. And so we'll do a B-scan, which uses sound waves to give a two-dimensional view of tissues. And this is very useful in detecting, looking, kind of ruling out any obvious pathology or for further evaluating like tumors and retinal detachments. And as I mentioned, this is what we'll use to image through a dense corneal or lens opacity. Now, in ocular oncology, when we're trying to measure like the size of a tumor, because that's really important for kind of guiding the next step in treatments and management. There's really skilled ultrasonographers, we call them, at various centers throughout the country. And ultrasound is usually the best tool for measuring the size. And what we really care about is like the height of a tumor. And that's where this really comes into play. Those people are much better than all of us at doing ultrasound, though. So we are typically just doing it as a ruling out things before we do cataract surgery on somebody with a dense cataract.
Yeah, because if we can't see the retina through their lens, like I've had a patient before who had a dense enough cataract where I couldn't see the back of the eye. And so when we're planning for surgery, if we do a B scan and it shows that they have a detachment of their retina, that helps guide our discussion with that patient, like, hey, we can do your cataract surgery, but we don't know how your vision is going to end up afterwards because you also have a detached retina. We don't know how long it's been like this. So it's helpful in education and then also, again, planning for surgery.
All right. And then as I kind of talked about, the optical biometry devices. So these are non-contact, and that's why they're widespread use because basically any form of testing that's non-contact is going to be adopted more by practices and patients for obvious reasons because people don't like things touching their eye unless they have to. It's also much quicker to obtain imaging. And so these devices use light waves or laser to measure the different distances between the ocular structures. And the nice thing about these that I'll touch on is that they all have built-in software that calculates the power of the lens within the information that's generated from the devices. So one thing that's a concern, or was a concern historically, and that I kind of touched on, is historically we would get these measurements and then we would transcribe them into a formula and then transcribe, or that would generate a power of a lens. Now, the obvious issue with that is that there's a high risk of transcription error. And, with the number of patients we see, and we're trying to always prevent any type of lens error. But that's an easy way to have a lens error because you're relying on, human error, manual transcription, things like that. It also required a lot of time. And so it's really nice that we had these formulas embedded into the software. So the same device that measures takes the measurements of the patient, prints out the recommended power of a lens in the same sheet. And as I mentioned before, we're always constantly updating these formulas. And the nice thing about these modern day machines that we can update the software to add new formulas and go from there. So kind of getting back to what we started with. So this is the different data produced by a biometer, like a LensStar, IOL Master, or Argos. We get the axial length, so how long the eye is, how thick the cornea is, which is also called pachymetry, the curvature, so the K, you'll see on the right there, K1 and K2, and the difference between those two representing your astigmatism, which is shown as AST to the right. The anterior chamber depth, which is key to what a fourth generation formula. So like Barrett True K is like a specific LASIK formula that uses ACD. The Barrett Universal 2 is a formula called Kane. That's a modern formula. There's one that's called Hygus. That's like another modern formula. These all require you to measure anterior chamber depth in order to generate a power lens. Otherwise, it'll give you an error. This also gives you something called lens thickness. So how thick the lens is. Sometimes that can be a good gauge before surgery to think about how dense a cataract is. And then, as I mentioned before, some formulas also incorporate white to white. Um, and, we talk through this and we heighten or we emphasize the importance of each of these measurements because it's really important that we get accurate measurements to deliver, accurate calculations for the procedure. And there's a number of different things that can impact the quality of the testing. Most commonly, things like dry eye. So if patient has a really dry eye, you can have blink to blink variation. You get a test where their eyes are very dry, that can produce inaccurate measurements. Most commonly, issues with the keratometry values or the Ks or the corneal curvature. You can also have like a corneal scar, some subtle changes to the outermost surface of your cornea called basement membrane dystrophy. These are all things that can affect the accuracy. As we kind of mentioned, a dense cataract can affect things. And then somebody who's, what we call a poor test taker. They're not good at fixating, looking off from where they're supposed to be. That can also affect the accuracy of the measurement. And so that's why we like to repeat measurements if we're not satisfied with the quality. And there's certain things that you'll get on the certain like cues you'll get on each device that says, few measurement results. It'll flag if it's a difference between the two eyes because sometimes that can be a flag of inaccuracy. And there's certain other things that can come up. So if you see that, if you feel like the patient, that you can get a better measurement next time, that's a good sign or a good threshold to repeat the test. All right, so pachymetry. So why do we care about the corneal thickness? So there's a number of like things that come into the management and like treatment decisions that we rely on pachymetry for. For one, we when we're talking about patient candidacy for different refractive surgeries like LASIK or PRK, we look very closely at the thickness because there's certain factors that can predict an increased risk of what's called corneal ectasia, which is basically means your cornea is being warped or changing after LASIK or PRK. And that's what we always want to try and prevent or rule out before doing refractive surgery. So in general, I look at this number when I'm thinking about LASIK or PRK, depending on the correction. If somebody has a less than 500 cornea, I almost always think of that as like a pathological cornea. There's something abnormal. And so those patients in my mind are not great LASIK candidates. Um, Now, if somebody has a really thick cornea, that might be somebody who you're more comfortable doing a higher myopic correction, so like a -7, -8, because you know they have a lot of tissue available for removal with the correction with the LASIK or the PRK. And then the other time we use this most commonly is when it comes to assessing risk or somebody's glaucoma status. So people having a thin cornea is an independent risk factor for glaucoma. So if somebody has like a borderline pressure, but they have evidence of glaucomatous cupping, and they're so for example, their pressure is 17, they have some early cupping or some early changes on their imaging, but their corneal thickness is like 5'10", that might signify they're at higher risk for progression of disease. And so you might treat that patient aggressively than somebody who has a pressure of 17 but has a 570 cornea and then doesn't have evidence of cupping or glaucomatous damage. And then also how thick your cornea is can also impact your quote unquote true IOP measurement. So um, a thicker cornea can mean you have a higher true IP, and then a thinner cornea can mean you typically have a lower true IOP. Somebody have a question? Let me pull it up.
Sure.
Yeah, the question reads, is it pretty standard across the board for anyone under 500 to
Okay,
not be
sure.
the best candidate?
So that's definitely dependent on the doctor. I would say in general, so yeah, it's very much dependent on the doctor. But to me, I think if you have a less than 500 thickness cornea, you start to get a little bit worried about LASIK. Now, PRK can still be an option in those cases, assuming the rest of the imaging looks fine. But yeah, in general, I would say most people would hesitate or pause to do LASIK on somebody with a less than 500 cornea. That's not to say that doesn't happen and people do well, but that's just kind of a common risk factor. So not a
And
clear cut answer, I understand, but
yeah, it's all patient dependent. Sorry, and I think I made this confusing. A thicker cornea means their eye pressure is going to measure higher than what their true pressure inside of their eye is. So I think that these two should be flip-flopped.
oh yeah, 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 yeah.
It has a thinner cornea, their pressure is going to measure lower than what their actual pressure inside of their eye is. So my apologies, those two are flip-flopped.
Okay, so anterior chamber depth. So this is the distance from the back surface of the cornea to the front surface of the iris. So when do we worry about this? So if somebody has a low ACD, it just means that they often have a shorter eye, or you may want to be cautious dilating that patient. So less than 2.5 is considered shallow. And the reason why you want to be cautious dilating that patient is because their angle, as you can see in the figure on the right, you can see how their angle can become closed, or they're much more prone to having a closed angle when they have a shallower anterior chamber depth. And so that's why we say, take caution if there is a shallow, ACD. So less than 2.5 is a kind of a good gauge for the ACD being shallow. In general, a 3.0 millimeter ACD is normal, and then greater than 3.5 is considered deep. You also might think about this when you're planning for surgery, just anticipating that you're going to have less space trying to take the lens out if you have a more shallow ACD. The other time we think about this is when we're planning for a what's called an ICL, which is a lens it's a commonly used for people who are higher myopes or very nearsighted, so like a -6, -7, -8. And we want to make sure that we have adequate space to insert the lens. And so the official on-label use is greater than 3.0 millimeters. And so that's why we look closely at the anterior chamber depth when we're planning for an ICL. So corneal curvature, I kind of talked on this a little bit earlier, but if you think about astigmatism as, astigmatism in general is your cornea is steeper in one direction than the other. This is an example of where horizontally it's more steep than vertically. That's called against the rule astigmatism. When it's steeper vertically than horizontally, then it's called with the rule astigmatism. And how these numbers correlate to what's shown in that picture there is, for example, if your cornea was measuring vertically at 45 and then at 100, so at 90 degrees, and then horizontally at 180 degrees, or horizontally, it was 43. So 45 versus 43, you would have two diopters of with the rule or vertical astigmatism. And so you would try and line up, if you were using a toric lens or astigmatism correcting lens at the time of surgery, with the steepest axis. So if you were steeper vertically at 45 versus 43, and that axis was at 90 degrees, then you would want to line the toric up at 90 degrees. Now, in the example on the screen here, this patient, their axis is steeper at 22 degrees. And it's probably not quite 22 degrees because these formulas incorporate some assumptions. But that's usually like a good rule of thumb. So this calculation is suggesting that we're going to put in a T5 powered toric lens, which I believe corrects two diopters of astigmatism at the corneal plane. And we're going to orient the lens at 22 degrees. And so we'll make marks either at the beginning of surgery, or sometimes we're using a laser within the surgery, and then we'll line up that lens to ensure that it's maximizing the astigmatism correction with the lens. And once again, the reason why we care more about what your astigmatism measured in your cornea versus your refraction is that if refraction includes both the contribution of the cornea and the lens before surgery, but we're removing that lens with cataract surgery, and then you're only going to be left over with your cornea. And that's why we care so much about what your corneal astigmatism is at the time of cataract surgery.
Yeah. And I think like if we only had one test that we could do when a patient comes in for an evaluation, if we could only grab one thing, it would probably be the Lens Star or the IOL Master or the Argos, because it gives us so much information and helps us plan for surgery. But the reason we're also testing the cornea and running the topographies is because the lens star isn't going to show us if it's an irregular astigmatism or a regular cornea. So we grab the topographies as well, because those actually show us the shape of the cornea and help us identify any irregularities that may be present, so that if we do need to address the cornea before cataract surgery, again, it just emphasizes the importance of how all of these things together help us enhance surgical outcomes.
The other thing that's nice about you might wonder, why do we get all these different tests, is that we like to see consistency. So if we get a Penacam, and then we also get like a NIDEC, or it's called an OPD, and we get a lens star, which biometry, if these all give us measurements of your cornea, and so if the measurements are consistent across all three devices, we feel pretty good about putting the lens in that position that's consistent across those three devices. So that's another value to getting multiple measurements with different devices. So effective lens position. This is the one thing that we cannot predict when we do cataract surgery. So we can't ultimately predict how somebody's eye will heal. And if you think about like how big your lens is, thickness wise, when we do cataract surgery, that's sometimes it can be 4 millimeters, but these lenses are much thinner than that. And so we're inserting a lens inside a capsular bag that used to be 4 millimeters thick into like a much thinner, I can't even remember the exact size of an IOL, but it's maybe a fourth of that. You can imagine where it's hard to predict where that lens is going to sit, if you're looking at the eye from the side, where the lens is going to sit, anterior to posterior. And that's why we, this is actually called the effective lens position, as it represents the physical position of the IOL inside the eye. But that will ultimately impact why, even though it was predicted to land at, no correction, you ended up landing at minus 0.75 after surgery, or plus 0.75, because we can't ultimately determine this effective lens position.
All right. Any questions for Dr. Ferguson or lens measurements or anything? Otherwise, we'll move into the next portion of this. All right, so like I said, the rest of the lecture is, thanks, Dr. Ferguson, by the way. The rest of this lecture will be covering additional tests that we obtain when patients come into the clinic, sometimes during cataract surgery evaluations or just new patient pathology when it comes in. So we're going to talk about a bunch of different tests. Initially, though, dry eye and tear film testing, because this is so important. Again, I think the one structure, I guess it's not necessarily a structure, but the one thing that was left out of that initial anatomy slide is the tear film. A stable tear film is so important in vision quality. And I'll kind of show you the different components of the tear film and how we assess for instability of it as well. Just a quick overview of anatomy for our tear film system. So we have our lacrimal gland that's located in the upper outer corner of the eyelid. This is where the tears are produced. Those tears then travel across the surface of the eye, and then they drain in these openings at the inner corner of the upper and lower eyelids called our puncta. The tears then travel through these cannuliculi and then into our lacrimal sac, and then they go down our nose, down our throat, or so this is why if you're crying, your nose starts to run because all of that excess tears are just draining out through your nose. So fun fact. So this is what a normal breakdown of the tear film is. So we have three major components. Our lipid layer is this outer layer of our tear film. So this is made up of oils and fats. And what this layer does is it helps keep the tears adhered to the surface of the eye. And so if we're deficient in our lipid layer, our tears evaporate very quickly off the surface of the eye because there's no lipid there to help adhere the tears to the surface of the eye. If you think of pouring like oil on top of water, that water can't go anywhere because that oil just sits on top of it. The aqueous layer is like the water layer of the tear film. This is the thickest layer of the tear film. And then lastly, adjacent to the actual surface of our eye is our mucin layer. The mucus layer just, again, helps keep tears on the surface of the eye. I think it's, this is a very simple breakdown. I think in reality, all of these components all mix together in order to, that's what forms our tear film. So there's two types of dry eye. We have our aqueous deficient, which is a quantity issue. So this means that there is insufficient aqueous layer, so not enough of that kind of water layer of the tear film. And then we also have evaporative dry eye, and this is by far way more common than aqueous deficient dry eye. And this is more of a quality issue. The evaporative dry eye means that there's not enough of that lipid layer of the tear film, which causes the tears to evaporate off the surface of the eye and can really affect the quality of the vision. There's many different ways that we test for dry eye. We'll go over different questionnaires, dyes, and some other tests that we use as well to help assess for dryness.
There's a couple questions, Dr. Steeps. One of them is, how often do you retest for dry eye?
Do we mean like rerun testing for patients who have dryness?
Yeah, I'm wondering if maybe like they've been tested in, let's say, November. When would be like, how often would you retest them for dry eye?
Yeah, so I think it varies patient to patient. Like if a patient is coming in for a cataract evaluation and they go through all of that testing that we talked about, and I'm looking at their testing and it's just inconsistent, immediately my mind goes to, okay, this patient probably has dry eye. And when I go into the room and I take a look at their eyes and they actually do have dryness, Then I say, hey, these measurements, they're inconsistent. I can't guarantee a great outcome with cataract surgery. So why don't we treat the dry eye first and then bring you back for repeat testing? And if we can prove that the dry eye treatment improves the overall measurements, then, we can better guarantee a successful outcome with cataract surgery. It's kind of one of those things too, where we want to make sure that everything else is addressed with the health of the eye, no matter what kind of disease or uh, uh, disorder is going on. Um, and it's dependent. Sometimes I feel like it's every single patient that I see that day who has dry eye and needs to come back for repeat testing. Um, and well, I see, what percentage of the patients do you see have dry eye? I mean, if you ask any patient, every single patient will come in and say that their eyes feel dry. It's so common. I would bear to say like 80%. But yeah, it's pretty common that we bring patients back. Again, we want to ensure happiness and success with cataract surgery. And it's dependent on the day and on the patient. But usually if we can get the dry eye under control, repeat the measurements, then we just feel more comfortable moving forward with cataract surgery. I think um, the time period for when I follow up with patients as far as dry eye goes, it varies on how severe the dry eye is. Sometimes it takes multiple follow-ups before surgery to really feel good about it as well. If eyes are very severely dry, I want to see them back, soon after we initiate treatment. Otherwise, sometimes it's every 3 months or 6 months. It totally depends on the patient. But many, many patients that we see have dry eye. It's so, so, so common. And a lot of times people don't even know that their eyes are dry. And then we look at them and I'm like, how do you not feel that your eyes are this dry? So as far as what I think is the best test for dry eye, we'll get into that a little bit. If I had to choose one, I would probably choose sodium fluorescein dye, and we'll go over that too. All right, so first off, we have our questionnaires. So these are just quick screening tools that we use for patients to determine if they have dry eye and if we should obtain further testing. So these patients fill out these forms and it usually gives some sort of score. There's multiple different types, like this is the speed, for example, but there's also OSDI and DEQS. Essentially, this lays out the symptoms of dry eye and patients rate it on a scale, and depending on what their result is, that tells us if they have dry eye and should we do more additional testing. Um, so this question, can you talk a little bit about LipiView versus IDRA? We'll get into devices in a little bit. I personally don't have any experience with IDRA to maybe give a good answer on that. But I can do my best. So we'll get into different devices that we use to treat dry eye as well. So here are vital dyes, as I mentioned before. If I only had one choice for what to use, it'd probably be sodium fluorescein. I think it can tell so much about the tear film as far as like stability and health of the eye and health of the surface of the eye. So sodium fluorescein is like a yellowish orangish dye that we place in the eye, and then we shine a blue light. And the way that the fluorescein in the dye reacts is that it just like really shines bright. And so the sodium fluorescein is going to highlight epithelial defects. So if a patient has a big corneal abrasion, it's going to look like a big green eye. And then also just dead and dying cells on the cornea. What this picture is showing is SPK, or superficial punctate keratitis. This is when cells of the cornea are dying off, and so they just kind of take up that dye, and it creates this appearance on the surface of the cornea when there's fluorescein in there. It also tells us the tear breakup time. We will get into that a little bit more, but essentially the sodium fluorescein mixes in with the tear film and on the surface of the eye, and it can give us a lot of information on the status of that patient's dry eye. We also have a couple others that we use every so often. Rose Bengal stains unprotected cells if the cells of the surface of the eye or cornea are unprotected by the underlying mucin layer, the pink dye will react with those cells. The most common time that I use this is if I suspect a herpetic corneal infection. The edges of an ulcer from a herpetic corneal infection will light up with rose bengal. And so sometimes it's a good differentiator when we're trying to make a diagnosis. And then lissamine green, usually this is used for like very, very, very severe dry eye in patients who have autoimmune disease, something like Sjogren's disorder. They're autoimmune diseases that can cause severe, severe dry eye. Those patients I usually use lissamine green in because they highlight conjunctival dryness. The conjunctiva is the clear structure that lies over top of the white part of the eye, and in very severe dry eye, patients will have even SPK of their conjunctiva. So that's helpful in determining, again, severity of dryness as well. So again, aqueous deficient dry eye, this is when patients are not producing enough of that aqueous or that water layer, which is produced by that lacrimal gland up in our eyelid. There's a few different ways that we can test for this. Main ones would be Schirmer's or the phenol red thread test. Usually how these work is you numb the patient's eye and then you place the device, whether it's the little piece of paper with Schirmer's test or the thread with the phenol red test, and you have the patient sit for 5 minutes with Schirmer's or 15 seconds with the phenol red, and you test how far down, like on the Schirmer's test, it'll get wet from the tears a certain amount. I like to numb the patient's eyes before I do this test, just because if they're not numb and if you put a piece of paper in someone's eye, what it creates is this like reactive tearing where they'll just like tear profusely. And so I don't think it's as accurate of a measurement. If the patient's eye is numb, then it just tests for their basal tear production, which is how many tears is your eye producing over the course of this 5 minutes with no other stimulus to produce tears. And so the normal test for Schirmer's would be greater than 10 millimeters. Usually these little pieces of paper, they have markings for millimeters. So that'll tell you how many tears they produce or how many millimeters, and that helps determine, is the dryness severe, is it moderate? And so that's helpful in distinguishing, okay, or should we be considering aqueous deficient dry eye as part of the reason this patient is having these issues. And then the phenol red is the same. You can see that it gets more red where the tears there, it causes this reaction where the tears cause this thread to turn red. And again, we just measure how far the tears travel along that thread in order to assess for level of dryness. And then moving into evaporative dry eye, like I said before, this is much, much more common than aqueous deficient dry eye. Usually aqueous deficient is more so from autoimmune disease, whereas most of the dry eye that we're seeing, I think is a complication of the lids. Meibomian glands we have 20 glands on our lower lid and 20 glands in our upper lid, and they open at the lid margin, which is the base of the eyelashes. And so the oil layer of our tear film comes from the meibomian glands. And again, what those are doing are helping keep the tears adhered to the surface of the eye. And so if we have meibomian gland dysfunction, which is the main cause for evaporative dry eye, it means we're not secreting sufficient amounts of oil into our tear film, and it creates the tear film. It causes that surface to break up over time. And that's why patients will say like, well, my vision feels better like if I blink, and that's because it's secreting more oil from those meibomian glands to help improve, or just momentarily when they blink, the tears will spread across the surface of the eye and the patient will feel like their vision is more clear. But the longer the eyes are open, it gives way for the tears to evaporate off the surface of the eye. And so that's why patients will say that they have fluctuations in their vision. So this is evaporative dry eye, meaning the tears are evaporating off the surface of the eye. And this is super, super common, especially now with how much we're staring at computer screens and phone screens all day. Every time we blink, our upper lid should touch our bottom lid And that is the signal for those meibomian glands to secrete the oil layer of our tear film. And normal, if you're just going to the grocery store or driving, we blink about 12 to 15 times a minute. Whereas if we're staring at a screen, the studies show we're only blinking about 4 to 6 times a minute. So less than half the amount of times we should be blinking. And so chronically, if we're not blinking enough, over time, those glands can become clogged because we're not getting that secretion of the oil. Also, things like inflammatory disease or disorders like rosacea can cause inflammation of those glands, leading to evaporative dry eye. Again, going back to sodium fluorescein, one way that's super quick check for evaporative dry eye is tear breakup time, or TBUT. So this is when we're putting that sodium fluorescein dye into the patient's eye. It mixes in with the tear film, and you have the patient blink 3 times and then hold their eye open, and you count how long it takes for that patient's tears to evaporate off the surface of the eye. So you can see in these photos, when the tears start to evaporate, those tears start to break up, and you get these dark spots where that sodium fluorescein is not lighting up. And so this is when you would say, if you count to 5, and this is when you start to see the tears break up, then their TBUT is 5 seconds. So normal would be greater than 10. So the patient sits there, they hold their eyes open, you count to 10, and they have no breakup of their tear film. I rarely ever see that, but I'm always excited when I do, because usually it indicates that they do have good lipid production. Moderate is about 5 to 10 seconds, and severe is less than 5 seconds. And some patients will blink and their tear film will immediately start breaking up on the surface of their eye. And so that can be an indication of pretty severe dry eye. And someone asked, is it common with someone with lag ophthalmos to have dry eye? Absolutely, it is. Lag ophthalmos means that when you blink, the top lid is not coming in contact with the bottom lid. And so if a patient is unable to close their eye, what that means is they're unable to secrete that oil, but they also can't spread the tears off across the surface of their eye. If you remember back in that quick anatomy lesson, the tears, they travel from the top corner of our eye to the inner corner of our eye. So if you're not blinking, the tears aren't traveling across the surface of the eye. So yeah, if a patient's eyes can't close completely, it can definitely exacerbate their dryness. So ways that we can treat meibomian gland dysfunction, really what we want to do is unclog the glands that line the eyelids, because if we can get out all of that oil that's kind of hardened and blocking the glands from secreting good quality oil, if we can get all that gunk out of there, it can kind of hit the reset button for patients. So initially we'll try just in office, we can kind of squeeze the glands ourselves behind the slit lamp, or we recommend patients use a warm compress. Because if you think of oil, if we think of butter at at room temperature, butter is hard. But if you heat it up, it becomes liquidy and runny. And so if we heat up the oils in our tear film, they become more runny, and we can, get rid of some of that oil that's clogging those glands. So that's where warm compresses come in. And I always recommend that after the patient uses the warm compress, to give themselves either a little massage on their eyelids or good strong blinks to, again, activate the secretion of those oils. But we also have actual devices like LipiFlow and TearLab, and those are actual devices that sit on top of the surface of the eye or hook on the eyelid, and they're treatments that heat up those glands, and then LipiFlow actually secretes the oil on itself. It kind of has a time period during the LipiFlow where it's compressing the glands and secreting those oils. And then TearLab, the oil glands are heated up, and then the doctor will actually go in and express the glands once that treatment is done. So all kind of the same idea. We want to get rid of the clogging of the meibomian glands and allow for better secretion of the oil layer of our tear film. And then we have our other diagnostic equipment. There's a lot of different products on the market that help us determine different types of dry eye. For example, Tear Lab is going to measure tear osmolarity. Osmolarity is like the number of particles that are within water. So high osmolarity means that there's a lot of inflammatory markers or other debris within the tear film. That's going to make the osmolarity read higher, and greater than 300 score on the tear lab can indicate dry eye. And these are also good tools to track over time. Okay, is the patient getting better? So if they initially come in and they do have greater than 300 score on their tear lab, that's something that we can use to track their improvement over time as we treat their dryness. Inflammadry is also kind of similar to tear lab, except it's looking for inflammatory markers within the tear film. The more inflammatory markers within the tear film, the more inflamed the surface of the eye is and the drier that it can become as well. LipiView, I know someone asked a question about this. LipiView is a camera that can image the actual meibomian glands. So if we look, here's a normal photo of the glands. They're nice and long and very consistent with each other. This is a picture of healthy glands, and so it's highlighting the glands and the oils within them. If it's abnormal, the glands start to atrophy over time. So if they're not having that signal to secrete the oil, whether it be from something like lagophthalmos or poor blinking or those inflammatory disorders, if the meibomian glands are not secreting that oil, then they start to atrophy over time because they're not being used properly. And sometimes this can become very, very severe, and that's hard to treat that kind of dry eye. Like I said, I don't have enough experience with Hydra to kind of tell the difference in how they image the glands. So I'm sorry, I
I think
can't.
it's probably based on like, can you guys hear me?
Yeah.
It's probably based on like preference of the clinician. I think the obvious advantage of IDRA versus LipiView is that it includes those other things, but they both include what's called meibography, so imaging the meibomian glands. And I think it probably comes down to like what you're more comfortable using versus IDRA versus LipiView if you're trying to image the meibomian glands.
Yeah, I think Hydra is more of like an all-in-one tool, and that it
Yeah,
can
correct.
do multiple different things, like assessing like how thick is that lipid layer within the tear film. It can measure the T-butt and the tear meniscus height. The tear meniscus is just how the thickness of the tears as they sit on the bottom eyelid. And then again, it can also image the glands. And so it's kind of like a one-stop shop rather than having the patient do multiple different things. So it's more convenience, I would say, would be the difference there. Okay, any other questions about dry eye? If you have gland dropout, can they regenerate? No, I don't. They can't regenerate, and so that's why it's important to catch these patients early and treat the meibomian glands, because once they're atrophied away, there's no way that we can like give them new glands, unfortunately. But maybe that's like a billion-dollar question. Okay, so we'll move on to color vision testing. This is something that we probably don't do all that often, and I'll just buzz through this really quick. So usually color deficiency, it's not that they're actually color blind. They can still perceive colors. They just don't perceive them the same as someone with normal color vision can. So color vision is all done by our photoreceptors. This is a scan of the macula in the back of the eye. The outer layers of the macula here, those are our photoreceptors. There's two different kinds. There's rods, which do most of our peripheral vision and our vision in dim lighting conditions, and our cones. Our cones are our detailed vision and our colors. So they're most concentrated in the very center of the macula because they help us perceive the highest detail or precise vision. And there's three types of cones. Our L cones are our long wavelengths or our red cones, and those are going to absorb red light. Our M cones are medium wavelengths, and those are going to absorb colors within the green spectrum. And then our S cones are our short wavelengths, and those are going to absorb the colors within the blue side of the spectrum of light. Most color deficiencies are inherited, meaning they come from someone in your family tree. Others can be acquired, meaning that they come after birth from either disease or damage to the brain. There's different ways that we classify them. There's anomalies, meaning you have all three types of cones, but you have a malfunction of one of those cones, maybe not enough cones, or their spectrum is shifted one way or the other. Or you can actually have completely missing one of the types of cones. So for example, tritanopia means you have absolutely no blue cones. And each of these deficiencies is going to change how patients perceive colors depending on if they're missing cones or if things are shifted. You can also get monochromatics. Those patients are missing 2 or more types of cones, meaning those patients are fully colorblind and cannot perceive colors. Like I said, most of them are inherited. Most of them are X-linked, meaning it's much, much more common in males than females. We see this, like it says here, 1 in 12 males and 1 in 200 females. So it's much more common in males just because of the inheritance pattern. Here is normal color vision. So how patients perceive normal colors across the whole entire spectrum. This is protanopia or absence of the L cones. So patients who have missing red cones, this is how they'll perceive colors. And then deuteranopia here is absence of those M cones. So different ways that they're still perceiving colors, just different from normal color vision. There's a couple different ways that we test this. Pseudo-isochromatic tests are quick screening tests where we can identify if a patient has a color deficiency. And then also our disc arrangement tests. For these patients, they're ordering discs in a series of ordering like how the color changes over time. And so this is how we actually classify those color deficiencies. So the pseudo-isochromatic tests, we're identifying if there's a color deficiency. The disc arrangement tests are when we're actually classifying what type of color deficiency they have. So this is I'm sorry, I'm going quickly now because I know we're way over time. Pseudo-isochromatic tests, they look like this. There's usually a shape or number or letter in a series of dots with the colored foreground and background. And then the disc arrangement test, this is when, again, you're ordering the discs in kind of color order. And then we can map how patients order them, and it helps to determine. So in this middle one here, it crosses over the protan line. So we know that this is an issue with those red cones is because it kind of straddles that protan line. So this is a way to actually classify these color deficiencies. And lastly, again, all of these tests are if we suspect that something is kind of off, if we're like, maybe this isn't a cataract, maybe this is something else. Some of these other tests are ones that will run, for example, the red cap test, which can assess optic nerve function. So if a patient has reduced vision in one eye, or a APD in the other eye, an afferent pupillary defect in the eye, they will actually, it means their optic nerve, like we talked about before, which transmits information from our eye to our brain. Essentially, what's happening is that the optic nerve is not functioning at the same level as the relative eye, and so you actually perceive the red color differently. And so you'll have a patient cover one eye. Usually you have them cover their bad eye first and say, tell me how, this is red. If this is 100% red, tell me how it compares to how the red appears in your other eye. And so you have the patient kind of switch between the two eyes. And this is a rendering that I found online. You can see here on the right, that red is nice and bright, where in the other eye, it is more dim. And so this can indicate that there's optic nerve dysfunction. And so sometimes we'll use this if nothing else is really making sense. If we say like, oh, well, your eyes are equal and your optic nerves look equal, sometimes there can actually be damage to the optic nerve beyond what we can see in the eye. And so this is a helpful test. It comes in handy if we're worried about something like multiple sclerosis affecting the optic nerve. So we use this every once in a while. Dominant eye is helpful when we're making surgical decisions for either refractive surgery or refractive cataract surgery. The dominant eye just provides more visual input to the brain's visual cortex. So most people have a dominant eye. Usually if we're doing monovision, which means one eye is seeing in the distance and the other eye sees up close, the dominant eye is the one that we'll target for the distance, and then the non-dominant eye we target for near. Lots of different ways that we test this. The photo shows a pretty quick way where you just have the patient look at something through a hole in their hands. Like I say, like make a little Hershey's kiss with your hand and look at my nose, and then whatever eye they're looking at through their hands is usually their dominant eye. Lots of different ways that we can test this though. Usually people wink much better with their non-dominant eye. Like I can't wink at all with my dominant eye. I just look silly. So I can really only wink with my non-dominant eye. Brightness acuity test, we get this on every single cataract patient that comes through. What this is going to do is measure the patient's vision in the presence of bright light. So we're simulating the patient driving at night. So sometimes we'll see cataracts that don't look all that advanced, but we'll see that their brightness acuity testing is very reduced. And so when patients are saying, man, I really can't drive at night, this is a way to actually quantify that. So cataracts, corneal scarring, anything that causes light scatter is going to decrease their vision under glare situations. So we do this on all cataract evaluations and YAG evaluations as well, just to see how limited is the vision, when driving at night. Just helps with getting things approved by insurance and stuff like that. Lastly, exophthalmometry. This is a measurement of how far the eyeball sticks out from the lateral orbital rim, or the bony structure on the outside of our eye. The normal eye protrudes about 16 to 20 millimeters, and it's usually equal between the two eyes. And so if there's a difference in the amount of proptosis, which is the eye sticking out, of greater than 2, that can be considered abnormal. So again, proptosis or exophthalmos is when the eyes bulge out from the orbit, which is the bony cavity that our eye and the surrounding structures sit inside. And so a lot of times this can be caused by thyroid eye disease. You guys have probably seen commercials on this, but thyroid eye disease causes the orbital fat to proliferate, which causes the eyes to start to stick out. And so if patients have proptosis of one eye or both eyes, sometimes we want to run additional testing or blood work or imaging to rule out something else that's within the orbit that's causing the eyes to protrude. Again, things like that can cause things like optic nerve damage, which can limit the vision, and sometimes this can be really mild. And so something that we rarely look at, but sometimes like to do, depending on each patient. And ophthalmos is when the eye looks sunken in. A lot of times this can occur with trauma, where the bones of the orbit, if they're fractured, the structures within the orbit can kind of fall into that fracture, and it can have an appearance that the eye is sunken into the eye socket. So I know that last part was a little bit rapid fire. Does anyone have any questions about any of those things that we reviewed? Okay, awesome. Well, thanks everyone. Oh,
Thank you so much, both. That was me just putting
oh,
the links to the quizzes, to the quiz for this week into the chat. Thank you both to Dr. Seeps and Dr. Ferguson for your time and education today. And we will see you all next week for week 9.
Thanks, Jamie. Thanks, Kelly.
Yeah.
Thanks, everybody.
Yeah,
Yeah,
have a
thanks
great
everyone.
day. Bye.